My name is Mary Lloyd Ireland. I appreciated the opportunity to participate in this Guardians of the Knee panel at the ACL study group in St. Kitts. My talk was on landing patterns and mechanisms to avoid the position of no return. The Guardians is a group of orthopedic surgeons who are very interested in prevention tactics, techniques, so we can reduce the incidence of injury to our particularly female athletes, but reduce the incidence of injury to the ACL. It takes 70 milliseconds to tear the ACL. It's valgus, rotation, out of control movement, as you can see here in this individual who's out of her core or cone of stability. Stop, cut, usually it's the momentum going forward, and it's this rotation or a pivot shift that occurs. So varum, valgus, rotation, out of control movement. The term position of no return was coined by me in 1999 in this Journal of Athletic Training article. And you can see the injury often occurs in the paint with rebounding in basketball. There's a stop, cut, change direction. The position is an upright landing with less knee flexion and less hip flexion, forward flexed lumbar spine, and a falling forward motion. As the ACL fails, she falls forward, and typically that heart attack of the knee is when she grabs her knee in a bent position, reducing the pivot shift subluxation. So if we think about avoidance of that position of no return, what needs to be taught by coaches and healthcare providers, physical therapists, athletic trainers, is alignment. So the position of safety shown on the left is normal lumbar lordosis, more hip flexion, neutral adduction, abduction, neutral rotation, greater knee flexion where hamstrings can be that agonist muscle, plantar flexion, neutral tibial rotation, and landing on both feet with balance of the posterior tibialis. The position of no return is what we want to avoid to reduce risk of injury to the ACL, and that's the body is forward flexed, rotated to the opposite side, hip is in adduction, internal rotation, the knee is less flexed in valgus, and the tibia externally rotates, and there's an unbalanced landing on the foot, typically with the shoe surface friction ratio 1 being that stops the foot abruptly. But I strongly feel the position of no return emanates from the hip and position of the hip, which then predetermines the ACL is going to fail. And it's a little harder to understand in the sagittal plane. We usually measure things in gait in a coronal plane, but in the sagittal plane, it's that anterior rotated pelvis shown on the right, and the hyperlordotic lumbar spine and head forward, body forward, creating that bad position of the knee and hyperflexion valgus. As far as the position of safety on the left, more neutral lordosis, and pelvis posterior, almost like a mad cat. And if we can teach some pelvis rotation exercises, this would also be interesting. And also core, meaning lumbar spine, planks, things to keep the lumbar spine in neutral and not hyperlordotic. So again, this normal individuals doing a mini squat. You can see on the left that frontal plane, and you can see the athlete on the right, the female, is in a Trendelenburg type position almost, where her opposite hip is naturally lower, and the pelvis is forward, driving her femur into adduction, internal rotation, and to remain upright, the knee goes into valgus and the foot is pronated. See that contralateral drop, hyperlordotic position of the female on the right, as opposed to the male on the left. Gymnastics. She's done this move many times, and you can see there's an awkward landing, grabs her knee, heart attack of the knee, ACL tear. Can't blame this on the shoe friction floor ratio. So one more time, she's a little out of control. It's almost like she has a little mini stroke, brain to body not aware. Boom, ACL torn. This position of no return, it's a functional pivot shift. It's not really knee valgus. We talk about valgus collapse Well, it's more of a rotational valgus collapse, and seen from the frontal plane it may look like it's valgus, but not from that sagittal plane. So the landing is a pivot shift. The knee, the tibia is anteriorly subluxed, hip is an internal rotation and adduction, and the femoral rotation is first internal, then external rotation. And that's where we get that whip-like action that we see in the mechanisms of injury. So there's anterior tibial translation, and that's what we see with valgus collapse. We don't see MCL injuries or lateral patellar dislocations with this ACL injury often. So it's more of a rotational, translational of the tibia and not true valgus. This is a non-contact but perturbated injury in soccer. You can see here where the cleat kind of gets stuck. This is an ACL tear, posterior lateral corner. So most ACL injuries, as we know, are non-contact. Is this avoidable? Probably not, but there definitely is a friction between the surface and his cleat that puts his knee in that position. So perturbated by somebody on his opposite side, posterior lateral corner ACL. Again, can we prevent this injury? Maybe not this one because of the perturbation and the speed and the cleat, but a lot of them we can reduce the risk of injury. By observing ACL injury patterns, it allows us to develop a hypothesis in the lab and take it to the field. We can use force plates in the field. We can look at gait, joint position, and muscle activation is critical to knee stability. We've got your agonist and antagonist muscles. And strength is not as important as the timing of activation. So the best thing is that the hamstrings fire on a flex knee. And the worst thing is that in a quad dominant knee, then in an extended position, this will cause anterior tibial translation. Guardians of the knee. What are we guardians against? We're guardians against prevention of ACL injury, re-tear after ACL reconstruction, tearing of the contralateral ACL, and more importantly, post-traumatic osteoarthritis. And is prevention possible? I do think it is possible. However, we need to continue to look at what are the factors which cause the injury. If we can prioritize those factors that cause the injury, then we can really work on objectively defining what we're doing with these prevention tactics, because the prevention is working. Injury prevention, ACL tears. It's really as simple as the ABCs. Avoid that position of no return. Land in the position of safety. And that's what we must teach our athletes. And it's all about agility, balance, core, and strength. ABCs. Simple. Teach it. Future collaboration is certainly welcome. I thank you for this opportunity. I enjoy being a guardian of the ACL and of the knee, and importantly, reducing risk of injury to our athletes.